Good evening, everyone. Welcome to our webinar. My name is Jason Jedlicka, and I'm here tonight to speak to you a little bit about Zenlens scleral lenses and ocular surface disease. And just as a disclosure, I'm a paid consultant for Bausch & Lomb Specialty Vision Products. So before we get into managing ocular surface disease with scleral lenses, I want to just give you a little background on Zenlens scleral lens. If you're not familiar, Zenlens started off as the standard set with 2 diameters, 2 shapes, thus trying to provide a scleral lens fitting set that could work for essentially any size or shape eye. The 2 diameters accommodate both large and small corneas. The 2 shapes accommodate both standard and reverse geometry needs. As we move to an era with scleral lenses where everything is moving towards depth measurements rather than curvature measurements, Zenlens is nice because everything is micron based. As you're adjusting sagittal height of the lens centrally, peripherally, or at the edges, rather than making changes in diopters or radius of curvature, you're making them all in elevation and microns. Zenlens also features the Smart Curve technology, which allows you to make changes to the inner or outer aspects of the lens itself without impacting the rest of the design, so that adjustments are straightforward, and having to make changes like increasing the diameter to achieve more limbal clearance, things like that are no longer necessary. It also, the standard Zenlens design has an extended landing zone to allow for full landing without a lot of blanching that you sometimes see with scleral lenses. And the microvault technology is really a great feature which allows you to fit the lens to landmarks such as pinguecula or small filtering blebs, where you may have an area on the conjunctiva that's elevated and it affects the fit and it causes redness or it causes a misalignment. And you can add a microvault, a focal elevation curvature change to the edge to accommodate that. Again, just to talk about some of the features of Zenlens in general, the Zenlens fitting set comes with a prolate series and an oblate series in both diameters, so that as we have need for fitting patients with, say, keratoconus or normal corneas, we have a series of lenses for those eyes. We also have a series of lenses for those patients who are post-refractive, perhaps post-graft, those patients with significant inferior or peripheral elevations like nodular degenerations or pellucid degeneration. Briefly to talk about how the Smart Curve technology works. The Smart Curve is just really a zone in the mid part of the lens. And the way it's designed is it allows you to make changes internal or external to this curve, and the Smart Curve is the only part of the lens that has to adjust to compensate. So for example, if we had a patient who we needed more limbal clearance because our lens was just landing on the limbus, or it's just too shallow of a fit and we want to increase that, we don't have to change the diameter of the lens, we don't have to change the base curve, the power. We simply can change the radius of curvature of this limbal clearance. The Smart Curve compensates, and now we've bought ourselves more room at the limbus. And again, the way that that change occurs is you simply designate how many microns of increased area you want over the limbus. If you want 25, 50, or 100 microns, for example, of increased limbal clearance, that's how you specify. You don't have to worry about how many diopters to change the curvature of any one of these curves. You simply just ask for it in terms of microns of elevation change. So again, the Zenlens we talked a little bit about. I also want to introduce you to ZenRC, which is the newer member of the family. The ZenRC, RC standing for regular cornea, was designed to be a scleral lens which could be fit towards more regular corneas for just refractive error, perhaps for presbyopia, or for those patients with ocular surface disease that need a scleral but happen to have a regular shape to their cornea otherwise. The ZenRC comes in also 2 diameters, just like the Zenlens, but the diameters are smaller. So 14.8 and 15.4 instead of 16 and 17 like Zenlens. In general, again, how do we choose the diameters? The set is very carefully designed, so it's just as straightforward as this. If you have a cornea which is below 11.8, which is an average size cornea, you're going to choose the smaller diameter every time, because the design is for that shape or that size of a cornea. If your corneal diameter is 11.8 or larger, you're going to choose the larger diameter. Again, there's no decision making there. You don't pick, well, I think I want the 16 or 17. You just follow the fitting guide. Again, within the XenLens set, there's two shapes for prolate and oblate eyes. Within the XenRC system, the lenses all have a generally prolate shape, although it's not as prolate as XenLens. Because XenLens was designed mainly for keratoconus on the prolate side and for refractive on the oblate side, the prolate series happens to be fairly steep centrally. The XenRC design, even as a prolate lens, is not quite as steep. If you have a XenLens XenRC fit on a patient's eye and you need to increase the mid-peripheral clearance because of the shape of the eye, or you want to decrease the central clearance, you talk to consultation and they can change the base curve, and it's all done by microns again. You don't have to worry about how many diopters. You simply say, I would like the center of the lens to have 100 microns less clearance, or I'd like the peripheral part of the lens to have 100 microns more clearance. And those changes are made by the software. Again, it was geared towards smaller lenses, more normal corneas, more regular corneas, less irregularities, so less need for that flexure resistance, if you will. And both sets have toric peripheral curve options within the fitting set. XenLens has a 3 steps flat by 3 steps steep toric PCs in the fitting set as an option. They're not all toric, but there are toric lenses within your set. And XenRC also has mainly spherical peripheral curve lenses, but also has some torics for those patients that you might need them for, 2 flat by 2 steep set. So the XenLens family of lenses has been approved by the FDA for indications for ocular surface disease management. And ocular surface disease is a really, it's a struggle for a lot of patients to manage. This is a huge issue of quality of life, especially in the moderate to severe ocular surface disease families. Those patients with significant dry conditions from graft versus host, Sjogren's syndrome, for example, the limbal stem cell deficiency patients from Stevens-Johnson or thermal burns, chemical burns, and especially the neurotrophic patients, we see those a lot, those individuals that need protection over their ocular surface because they don't have proper innervation, they can't sense that their eyes are dry. And those with corneal exposure for a variety of reasons, Bell's palsies or what have you, where they can't close completely and that puts their ocular surface at risk as well. All these patients are potentially candidates for scleral lenses because the scleral lens creates a different ocular surface. It protects the cornea and shields it from exposure and shields it from the dryness and the lack of lubrication, from the lack of a tear layer. We still need to manage the patient's ocular surface disease, but it becomes less a matter of managing the corneal problem than it is managing the lens surface and the rest of the eye. So I have a couple cases that I'll use to kind of talk through how scleral lenses can be used in ocular surface disease. We'll go through these cases and then we'll talk again a little bit at the end about how we manage them. The first patient I'll talk about was a 62-year-old female who presented for an evaluation. She's post-operative acoustic neuroma removal on the left side with subsequent cranial nerve 7 paralysis. So again, we talk about someone with a nerve paralysis with exposure due to an incomplete blink and also some lack of innervation, creating a neurotrophic condition here. In addition to that, she has had radial keratotomy in both eyes back in the 1980s, creating some irregular corneal surface, irregular astigmatism, and an oblate-shaped eye. Interestingly enough, her chief complaint is blurry vision, left eye greater than right eye more than anything else. But her secondary complaint is that her eyes do feel dry, left eye more than right. She is using a lubricating agent at night and artificial tears every hour or two during the day. She enters for evaluation at 20/70 on the right eye and 2800 on the left eye uncorrected. We did attempt to refract her and got a little improvement on the right and not much improvement on the left. You can see the fluorescein image of her left eye and how dense the staining is. And this again is with her using a lubricating ointment at bedtime and artificial tears every hour or two during the day. You can see obviously that her eye is dry. You can also see how this impacts her quality of vision in addition to the dryness. And again, because of her situation where she doesn't have really good corneal sensation, the dryness part of this is not her biggest complaint. It's how the dryness impacts her quality of vision that she's most aware of. So all things considered here, knowing what her corneal topography looked like, because we were able to do a topography of her other eye to get corneal information. And the beautiful thing, of course, is that generally speaking, corneas are symmetrically sized and regularly or symmetrically shaped normally. In her case, we knew that she had a little bit larger cornea than normal. She also had RK, so her central cornea was flat. So in her case, it seemed most applicable to use a standard Zen lens design with a reverse geometry or oblate shape in the larger 17mm diameter. So eventually she was fitted with lens number 23 and 8.5 base curve, 17mm diameter, oblate design. Prescription was -6.25 with a steep one-step peripheral curve system, which we just decided after evaluating the lens that it looked a little loose around the periphery, and we decided to steepen it up slightly. Immediately with the lens on, her vision improved to 20/60 at the time of the fitting. And here again, you can see a picture of the fit. You can see the things we're looking for in a scleral lens fit. On the left, you see the overview of the entire eye. You can see a general diffuse fluorescein pattern that looks pretty even and symmetric over the entire cornea. You see fluorescein that extends beyond the borders of the cornea out to the limbus and a little beyond. And then you see also that the edges look like they're laying properly against the sclera. And so this looks like a generally good fit. And we can move to looking at the vault in this case. So we take our slit beam down to an optic section and evaluate the clearance that we have. And again, at initial fitting, what we've got is a vault thickness, which is essentially similar to the lens thickness, or 350 microns. So for an initial fit right out of the box, lens on the eye for 20 minutes, a vault of about 300 to 350 is good, assuming that we're going to lose another 150 over the course of the day. We end up with a final vault, hopefully around 200. So she was fitted and dispensed lenses, followed up for proper care. I had an opportunity to see her again 4 months later for a follow-up again, and just using this visit as kind of a progress check for her where she's at. She comes in using the scleral lens daily, about 8 to 10 hours. Her best corrected vision in the right eye, which is the eye that she does not use the scleral lens in, is still 20/40 with glasses. Now with her left eye, with the scleral lens and no glasses, she sees 20/25 -2. So this is her bad eye is now actually sees better than the good eye because of the right eye's irregular astigmatism post-RK. She really has no complaints with her left eye. Her chief complaint coming in at 4-month appointment is that her right eye is blurry, because she's aware of the fact that the left eye has improved so much with the scleral lens wear, both in terms of the healing of her cornea, but also the optics of the lens, which correct her irregular astigmatism. At this 4-month follow-up, we were able to take some photographs of her eye and see where things stand. You can see this is after lens removal. Her cornea is not perfect. There's still some mild staining on her cornea, which is very typical for someone who had as severe a staining as she had prior to fitting. But again, it's a world of difference in terms of the quality of the ocular surface here. And again, she's comfortable. She never was that uncomfortable, but her vision's greatly improved, and that's the key component here. She's happy with the quality of her vision and her eye. So just to kind of summarize this case, some key points, some pearls. It's important to recognize with some of these dry patients, and certainly not all of them, because many of them suffer greatly with the symptoms of dry eye, but many of them actually have just as much of a complaint about the vision as the way their eye feels. And if you look at some studies that have been done and patients that have been surveyed who have severe dry eye, many of them report the visual symptoms are nearly as significant as their symptoms of pain or irritation or discomfort. Using a scleral lens to help heal the ocular surface improves the vision, and typically what happens is in this case we put the lens on initially and the vision's 20/60, but as that cornea heals and the surface of the cornea improves over time, it continues to get better. And you see this time after time, that the vision improves by several lines of acuity over time and continued use of that lens. And again, this is a great example of not every dry eye or ocular surface disease patient is going to have a normal, shaped cornea. This is an individual who had radial keratotomy, had a really flat central cornea, and required a lens design that not only could help her ocular surface disease, but it would accommodate the shape of her eye properly so that she had the best possible outcome. And so thinking about those patients who are post-surgical or have various types of ocular surface disease, in addition to other problems, having a lens design with reverse geometry and variable diameters and things like that really allows you to customize and get the best possible fit for that patient, not only for their ocular surface disease, but for their eye in general. So we'll move on to case number 2. In case number 2, we have a 60-year-old female who presents by referral from a local ODMD group for a scleral lens fitting. She's been followed by this group for 6 months, ever since she had herpes zoster on the right side of her face, which affected her eye and created a neurotrophic keratopathy on the right eye. Her chief complaint, again, is blurry vision and a feeling of dryness in her eye. She is using gel drops, ointments, humidifiers, you name it, all the things that she should be doing to try to help, especially in this neurotrophic environment. She's also taking medication for her post-herpetic neuralgia. You can see upon her initial presentation, these pictures were taken at her initial visit, her initial consultation for lenses. She's 2200 with her current glasses. She does pinhole a little bit better than that. But again, you can see by the surface of her eye how dry it is, how irregular it is, how there's this ridge of epithelium, if you will, that's thickened and redundant, that it's no wonder that her vision is only 2100 given her ocular surface. So in her case, the initial presentation, I chose to fit her with a Zen lens also. I chose a prolate design because she had a normal corneal shape. Given, again, her other eye being relatively normal, I was able to do topography of her left eye and use that data to help fit the right eye. That allowed us to measure the corneal diameter. It allowed us to get an idea of her sagittal height of her cornea and the ocular surface in general, so that we were able to quickly put it and fit on her right eye with the appropriate lens. So we went through a fitting. We chose the Zen lens with a 7/8 base curve, 17mm diameter, prolate design, -1 was the final prescription. We chose it Boston XO2 again to try to get optimal oxygen to the cornea, and a final sag of 4800 microns. After 30 minutes of settling, we had a vault of about 300 microns, which again I felt was reasonable for an initial fit. And we ordered the lens with a center thickness of 0.35, which is standard for Zen lens. Through this initial lens, she was 20/80, and I felt like I was doing the right thing in terms of being conscious of the needs of her cornea at this point. Having fitted many neurotrophic corneas, this was just kind of a standard fit in my opinion. She did return a week later for her follow-up and dispensing. The lenses were dispensed. We went through the care and handling process. We instructed her on non-preserved unit dose saline to fill, hydrogen peroxide for storage and disinfection when the lenses were out, or when the lens was out. And then my feeling at this point, because of how bad her epithelium looked, was I wanted her to wear the lens essentially all waking hours to cover that ocular surface. And again, standard procedure for me in many cases, that's how I like to do it, is to have the patient wear the lens, as much as they can to shield that ocular surface from the external environment. Follow up in a week. So she comes back a week later, and her chief complaint is everything was great for the first 4 days. Everything was great, the vision, comfort, and then just the last 3 days, the vision's gotten increasingly blurry. She comes in and seeing 2800 in the right eye with her contact lens in. And what we've got now is, you can see that the cornea surface looks better, but at the same time, she's got significant bullous keratopathy. So what I've done as her contact lens practitioner is I've induced some corneal edema, which developed into some significant bullae, which were now affecting her quality of vision as well. So Sometimes we have to take a different path than we plan. In this case, we had to pull her out of her lens temporarily, manage her bullous keratopathy with steroids, hypertonic ointment, and discontinue her lens for a week. At that point, we wanted to make some changes. So I did a refitting even while she was there with this corneal edema, and I moved her into the XenRC design. Smaller lens, shallower vault, thinner lens, keeping her in the highest oxygen material possible. Again, trying to be even more conscious of her corneal demands for oxygen and still somehow cover her epithelium and provide her with that surface coverage. So she comes back a week after pulling her out of her lens, putting her on medication, and having refit her to pick up her new lens, which is the XenRC with all the modifications, smaller, thinner lens design with less vault. And at that point, her corneal edema is basically resolved. Tapering her steroid, reducing the hypertonic ointment, pick up the new lens, and let's limit wearing time to 6 hours a day until we get a chance to see how the eye responds. And if it does seem to deteriorate, then we would like her to call and talk to somebody right away. Well, the great news was she came back a week later and there was no corneal edema. So all the things that we had implemented, having her using a hypertonic ointment when the lens wasn't in, having her use the lens on a limited basis, all the other factors which we changed about the lens design to optimize oxygen, we're able to keep her cornea clear. Her vision now with her scleral lens is 20/50. She's still comfortable with this different lens. Her epithelium's looking much better. Again, the edema is resolved. And now that her epithelium looks good and her endothelium and her corneal edema is clear, I can see her endothelium, which looks just completely ravaged from the zoster, and which is why she obviously got corneal edema. So in her case, she had an eye that was significantly at risk for corneal edema with scleral lens wear. It was just really impossible to see it at her first 2 appointments because her cornea was so opaque from epitheliopathy and then corneal edema. So we continued the course of wearing the lens 6 to 8 hours a day, or 6 to 10 hours a day, depending upon how dry she's feeling. We have her using it kind of, she's a very astute person. She kind of gets a feel for how much she needs it, how dry her eye feels that day. She's going to wear the lens a little more some days, a little less others. Coming back 3 months later again, without her contact lens, her vision's 20/40. With her contact lens in, with the scleral, she's 20/20 -1. And you can see how clear her cornea looks at this point. There's still a touch of central haze there just from this chronic epitheliopathy, but it's not the type of haze that's going to keep her from seeing well. She continues to use the hypertonic ointment at bedtime, wear the lens 6 to 10 hours a day, and wears it again a little bit more in certain seasons, a little bit less in others. And she's now been in this lens for 2 years. She did have a flare-up of her zoster, which created some inflammation, and yet at the same time, the the epithelium looked intact during that whole time. So using the XenRC as an option for ocular surface disease, it has a smaller diameter, which for some patients is better. It may be difficult if someone's got a smaller aperture, a narrow aperture. It may be a situation where someone may have some scarring from pemphigoid or something of that nature, where a larger diameter lens is difficult to work with. And so a smaller diameter in this case can be preferred. A thinner profile can provide more oxygen to the cornea, and specifically in those cases where we've got endothelial compromise. We can't forget that there are situations where just because a person has anterior surface epithelial disease, that they still may have posterior corneal disease at the same time. We want to make sure we balance, again, the epithelial health with acceptable wearing time to avoid other potential problems. And again, my experience in most cases is that most patients with ocular surface dry eye disease do better wearing their lens as much as possible. But this is a great example of those cases where there is concomitant endothelial disease, and in these cases, she cannot wear her lens as much as she wants to, or as much as all waking hours. So again, when we're looking at the anterior surface, we're looking at ocular surface disease, don't forget to check the endothelium, particularly if a patient has been through an infectious process where the endothelium can be damaged. These are cases where we may not want to be as aggressive with using the lens for surface management as we would if we didn't have endothelial disease. So it's important also as we go through this process to not forget one thing, and that is that even though we're managing an ocular surface disease for a patient well, so we fitted them with lenses, we're improving their vision with GP optics, we're healing their cornea, we're making a lot of their symptoms of blurry vision and their symptoms of pain and irritation go away because the cornea, which is the most sensitive part, has been healed or is protected. We have not cured their dry eye or their ocular surface disease. We've only shielded the cornea from bearing the brunt of their ocular surface disease. What that means is that we still have to manage the dry eye condition as aggressively as we ever did, even though we're fitting them with the scleral. The dry eye condition has not gone away. For the lens to function properly visually, and for the lens to function properly to avoid buildup of deposits and drying of the lens surface, we need to keep that surface of the lens lubricated, just like we would the surface of the eye without the scleral lens. So again, it's important that we don't think of the scleral lens as a cure for the condition. I'm just going to fit this person to scleral and all of their problems will be solved. That's not the case. It's a crucial, vital part of managing ocular surface disease, especially when the vision is reduced. When the vision is reduced and the patient has reduction of quality of vision from their ocular surface disease, a scleral lens is often the best approach to help with the vision as well as their symptoms. But we also cannot forget to manage their dry eye condition for the benefit of their contact lens surface function. When we fit scleral lenses, we have all the same applications as any type of contact lens. We need to be careful how we're using it. We need to be wise. We need to realize that we may be using other medications at the same time and how they would interact with the lens. And yet at the same time, we have to make decisions as practitioners for what's appropriate use of certain medications at the same time as the scleral lens. And in patients where there's significant ocular surface disease, we have to be willing to make the right decision for the patient. So we have just some disclaimers here regarding safety information for scleral lenses and for GP materials. Thanks again and have a great evening.